Virilising tumours. Pathophysiology. Virilising tumours may be either adrenal or ovarian in origin. Both are likely to present in middle age, and the greater the tumour size the higher the likelihood of malignancy. Epidemiology. Very rare, accounting for less than 1% of all causes of androgen excess. However, because of the potential for underlying malignancy, they must be considered in the differential diagnosis of the hirsute/virilist woman. Clinical presentation and physical signs. Presentation is generally later in life compared with polycystic ovarian syndrome. Clinical manifestations typically include menstrual irregularity, which can be associated with anovulatory cycles, hirsutism, acne, deepening of the voice, frontal balding, androgenic alopecia, muscle hypertrophy, and cleidoromegaly. Importantly, a rapid onset of severe symptoms should alert the clinician to the possibility of an underlying androgen-secreting neoplasm. Abdominal pain with a palpable mass and/or ascites may be present, especially if the underlying cause is an adrenocortical carcinoma. Features of Cushing's syndrome should also be sought as some malignant adrenal tumors secrete androgens and cortisol. Childhood presentations include precocious puberty and/or virilization. NB. Causes of androgen excess in women. Polycystic ovarian syndrome, greater than 95% of cases. Obesity, and associated insulin resistance. Androgen-secreting tumors, adrenal or ovarian, benign or malignant. Congenital adrenal hyperplasia. Cushing's syndrome, ACTH-dependent or adrenocortical carcinoma. Acromegaly. NB. With large adrenal tumors, greater than 5 cm diameter, the possibility of adrenocortical carcinoma must be considered. Investigation. Androgen profiles. One or more serum androgens dehydroepiandrosterone sulfate, DHEAS, androstenedione, testosterone are typically raised. DHEAS is synthesized exclusively by the adrenal gland, and thus an elevated level indicates an adrenal origin for hyperandrogenism. In contrast, a markedly elevated serum testosterone in a postmenopausal woman with normal DHEAS and androstenedione strongly suggests an ovarian source. Mildly elevated adrenal androgen levels may be seen in a variety of non-neoplastic conditions. Measurement of DHEAS and androstenedione after the administration of dexamethasone can help to determine which cases require further investigation. Adrenal androgen production is ACTH-dependent and failure of exogenous glucocorticoid to suppress circulating levels suggests an autonomous basis for hyperandrogenism. Similarly, gonadotrophin-releasing hormone analogues can be used to switch off non-tumoral ovarian androgen production. Other endocrine tests. Gonadotrophins. In women with regular menses, who are not on the combined oral contraceptive pill, further tests are probably not necessary. Otherwise, luteinizing hormone, follicle-stimulating hormone and estradiol concentrations should be measured. 17-alpha-hydroxyprogesterone. To screen for congenital adrenal hyperplasia. Urinary free cortisol and dexamethasone suppression. If Cushing's syndrome is suspected. Radiological imaging. Adrenal CT and/or MRI. An adrenal CT or MRI with contrast should be undertaken if an androgen-secreting adrenal neoplasm is suspected. If adrenal malignancy is considered a possibility, then more extensive imaging of the chest, abdomen, and pelvis is required to look for evidence of local and distant spread. Pelvic ultrasound and/or MRI. Ultrasound, especially transvaginal, provides excellent visualization of most ovarian neoplasms. MRI with contrast is reserved for those cases in which the ovaries are not clearly seen or if malignancy is suspected. Treatment. Surgery is the treatment of choice for both benign and malignant adrenal and ovarian neoplasms. Adjunctive chemotherapy and radiotherapy can be used for malignant tumors, although response rates are often disappointing. Mitotane is the chemotherapeutic agent of choice for adrenocortical carcinoma. Prognosis. Although surgery cures the majority of patients with benign tumors, some clinical features such as deepening of the voice may persist. Prognosis for malignant tumors is poor, with overall 5-year survival rates of less than 40%.